And we are recording and we're on speaker view. Okay, Ted, I'm going to turn it over to you.
All right, thank you very much. And welcome everybody to another one of our sports science initiatives conversations. Today, we're very fortunate to have Dr. Glenn Barnes joining us. So Dr. Barnes is a primary care physician who has a fellowship in sports medicine, which is actually very unusual. There's probably less than there's just a handful of them in Las Vegas. So it's a good opportunity for us to have a nice conversation with someone that really does know quite a bit about sports medicine. He is currently working for UNLV Sports Medicine as one of their clinicians. He also works with several of the professional teams in Las Vegas, and is currently actually working with the School of Medicine on their COVID-19 testing initiative. Dr. Barnes also went to school in Las Vegas. He went to Toro University for his doctoral, or his MD. So one thing we're going to do is just going to be a little bit of a disclaimer and waiver. So the medical information on this recording is not intended to be a substitute for medical advice, diagnosis, or treatment. No doctor-patient relationship is formed. Please always seek the advice of your physician or other healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay seeking it because of something you've heard on this recording. Okay, so let's talk about our topics today. So we have three main topics we're going to go over today, and then potentially have a chance for some questions. We're going to try and keep this right to an hour with respect for everybody's time today. So the three topics we're going to talk about Zone 2 training and the metabolic benefits of Zone 2 training. We're going to talk about hamstring and hip flexor overuse injuries in endurance athletes. And then we're going to also delve into a little bit of platelet-rich plasma or PRP injections. So Dr. Barnes, which topic would you like to start out with today?
I have them organized: Zone 2, hip flexor and extensor overuse, and then PRP to finish off.
Okay, awesome. So why don't you talk us through what Zone 2 training is and what kind of maybe the metabolic benefits of it are?
Sure. So Zone 2 training is the level of exertion that an athlete can remain at before they start dipping too far into their glycogen stores and to burning carbohydrates. Classically, there's 5 zones. Zone 1 is just resting, as we all are sitting here, or a very easy ride in which you could hold a full conversation with no problem, all the way up to Zone 5, which is your maximal sprinting effort, which mere mortals can only do for about 30 seconds, and then you're done at that power output. And the magic, at least for endurance athletes, really revolves around improving Zone 2. And what Zone 2 primarily is the exertion in which you're burning the maximum amount of fat. You are not dipping into glycogen stores, and all the metabolic byproducts such as lactic acid or lactate can be reused within the muscles and does not need to be exported to the circulation to be recycled through the liver, back to sugar, then back to the muscle. So Zone 2 is really critical for athletes because if you can train this zone, your baseline cardiovascular capacity will continue to increase. You will continually be able to remain at a higher power output without dipping into your limited energy storage, which is really your glucose, which is really the carbohydrates, the glycogen. Oh, no sound.
So that's great. So other than, obviously for athletes, it's a real benefit. Is there benefits of Zone 2 work for non-athletes as well?
Oh, yeah. So Zone 2 is actually one of the largest predictors of metabolic disease that we've come across in athletes, non-athletes, and even metabolically sick people or ill people such as diabetics, overweight, metabolic syndrome. We see orders of magnitude difference in people's ability to perform Zone 2 exercise. And when I say ability, not that they can't do the work, but how much work are they doing before they break through zone 2 and enter into zone 3? You know, a diabetic person might only, this is watt output term, so everyone here is a triathlete and knows bikes. A diabetic person might only be able to put out 80 to 100 watts, you know, for 15 minutes before they start crossing into zone 2, you know, versus an elite cyclist or an endurance athlete might be able to maintain 300 watts indefinitely and never cross into zone 3. So these are orders of magnitude difference between someone who is metabolically healthy, such as an endurance athlete, which is the perfect metabolism, versus someone who's very ill, such as a type 2 diabetes.
Awesome. Yeah, I think that's an important thing to understand, is that this is not just endurance athletes. This is a lifestyle thing as well. And, you know, for many people, and I think you mentioned diabetics, but just people that with metabolic syndrome, maybe not even diabetes,
Yeah.
you know, just going for a walk will put them in zone 2.
Yeah.
And, you know, that's why we hear, you know, from the ACSM, the AMA, that, you know, 30 minutes of a brisk walk 3 times a week has so many benefits. And that truly is for a lot of people, that's zone 2 training.
Yeah, and I think it's very, very important to note that the dogma or the societal view of exercise that it needs to be difficult, that you need to be panting and sweating and working your tail off. And in terms of metabolic health, in terms of improving your body composition, and in terms of fuel usage, that when you're exercising, it's actually quite the opposite. You just need to put in a little bit of work, but the trick is sustaining it for the right amount of time with enough frequency to make your body adapt to the changes, become better. And then eventually, when you do that for long enough, you're going to need to start running in order to get into zone 2, or cycling hard or swimming hard or whatever your sport may be.
So is there a way that someone can determine how they would get into zone 2?
Well, there's a way that requires money and resources, and then there's a way that you just kind of ballpark it. So we'll start with the one that requires money and resources. So the best way to identify where your threshold of zone 2 is before you cross zone 2 and go into zone 3 is something called a lactate test. So lactate is a byproduct of muscle metabolism. So as your muscles are working, doing whatever exercise you're doing, you are creating energy. And a byproduct of that is lactic acid, which is then exported into the blood and is picked up as lactate. The easiest way to do this is with a finger prick. So much like someone might check their blood sugar, same thing, it's a finger prick. You put it onto a strip, it goes into a meter, and it gives you a number. Everybody has lactic acid or lactate in their blood at all times. Resting values for everybody is somewhere between 0.7 and 1 typically. Highly trained athletes can even have resting lactate lower than that, but by and large, it's 0.7 to 1 millimoles per deciliter is the measurement of lactate. So when we start exercising, obviously, we're going to be burning more energy. Our muscles are going to be working more. So that pathway is going to produce more lactate. So we are going to see it go up. But the trick is we don't want it to go too far, because once it goes too far, it indicates to us that we've tipped from fat oxidation and tipped over into sugar oxidation or carb oxidation. And that number is about 1.8 to 2.1, somewhere in there. So if you're exercising and you're able to maintain a steady state for 5 to 10 minutes, and then you check your finger and you're somewhere between 1.8 and 2.1, when your baseline was 0.7 to 1, you were successfully in zone 2. So that's the fancy way to do it. You can also do it with monitoring gas exchange. So you wear a mask that covers your face, and the machine that has 2 tubes going in and out into a machine, and the machine is analyzing the gases that you're inhaling and then you're exhaling. And we can tell just based on some simple chemistry how much oxygen's in, how much CO2 is coming out, and oxygen coming back out. And then we can compare those numbers to see, are you preferentially burning fat or have you tripped into burning carbohydrates? So those are the two very fancy ways in which to do it. There's two simple ways that all of us can do, and one is based on heart rate, and then one is based just on how you feel. The heart rate, there's three different equations you can use. The one that has the most, I don't want to say up-to-date research, but the one that seems to be most pervasive amongst the endurance athlete community is you take 208 and you minus 70% of your age. So let's say, I don't want to do math right now. Take 70% of your age off at 208, and that's your maximum heart rate. Zone 2 is anywhere from 60 to 70% of your max heart rate. So just stay in that zone. So do the math of what 60% of your maximum heart rate and what 70% is, and just stay in that zone. So that's one way to do it. Once again, that does require a heart rate monitor. So a little bit of an expense there, but I recommend the chest straps. The chest straps are more accurate than the wristwatches. Then the final way to do it is if you don't have any of this equipment, if you can speak in full sentences, you have not broken into zone 3. So the best way, if you don't have any of this equipment as you're going out running, I did it this morning. I just tried to say a full sentence while I was going. And if I could not get the last word out of the sentence, I had to slow down just a little bit until, once again, I just started talking to myself on my run. But if I could get out a full sentence on my run, but just barely, I knew I was right at the end of zone 2 before I tipped into zone 3.
For me, what I like to do, if I don't have any of the other metrics, and I'm fortunate I work at a place where we have all these metrics we can measure, but if I can breathe through my nose for a significant amount of time, I know I'm still in zone 2. And it's,
Okay.
I'm not requiring myself to exchange that much gas.
I got allergies, so that could get messy.
I know, and that's the problem. Like that's the one caveat. In the spring, it doesn't work because there's just too much mucus being produced.
Yeah.
But that's another way to do it. Okay, so and I guess part of the problem with the simple methods, unfortunately, is as we become more adapted to zone 2 training and to fat oxidation, those numbers don't work very well anymore.
Correct.
Right.
Yeah. So I would almost venture to say, because I myself have only done a half marathon, I've never done a triathlon. I did 2 Tough Mudders, so like I am nowhere near you guys. But I will say that when I was training for that, I did notice that 2 months in, 3 months into prepping for this event, I had to run a lot harder, and the heart rate thing no longer worked. Because my heart rate would be above the zone that I would calculate, but I could still speak in full sentences. So clearly, I needed to push harder. So I would say people who would be viewing this, the Triathlete Club, I would really look into resources in the community about who might be able to provide you with these tests. I think it is a worthy thing to spend some resources on, because time and time again, identifying this zone and training this zone has resulted in better performance on race day.
Yeah. So I'll just add in, one of the things you can do is, reach out to people at UNLV. If there's research going on, oftentimes these are things that we're measuring during research, and we may not be looking at that exact thing, but we could give you the raw data potentially, depending on the study, and you could actually interpret it. So that's great. So let's take some of the middle of the pack triathlete. Okay, they want to get better. What would they have to do to, I guess, minimum effective dose, do you think, to change where their zone 2 was?
So the minimum effective dose for even a middle of the pack triathlete is going to be different from a minimal effective dose for your general population. So the recommendation is you have to periodize. Did I say that right?
Periodize, yep.
Yeah, the training cycles, just like everything else. All right, periodization works. We've known that for years and years. So it all starts preseason. So pick a race, pick the start of your season, whatever it is, back up 4 months. So you need to start at least 4 months early, and you need to do zone 2 training for at least 3 to 4 times per week. And a triathlete should really be aiming for an hour. That's really what's preferable for a triathlete to start to see these differences. And maybe one of those training sessions per week, one of the 3 or one of the 4, whatever you're doing, should go longer, maybe 90 minutes, maybe even up to 2 hours. Although coming up to 2 hours, we start to get into different requirements that might change as far as needing to replenish with energy before the run's over. So I would recommend a minimum of 1 hour for anyone who is already a triathlete and who really wants to start pushing their performance.
Yeah. And you know, a lot of the triathletes are doing that. But I think the issue oftentimes is they're kind of going a little bit too hard and they're in zone 3 and they don't recognize it. Because like you said, you know, unless we're working hard, we're not having the benefits, but there are so many metabolic benefits at zone 2.
I mean, and I did it myself this morning. I was just, it's so hard to convince people you have to go slower. You have to go slower to go faster, because going slow builds your base, and going faster just trains your ability to pull sugar out of your liver and out of your muscles quickly for a sprint. It's people look at me so weird when I tell them you have to go slower.
You know, it's interesting when we look at the energy systems. Anything we do in triathlon, anything we do is aerobic, right? The shortest races we do, that most people would do would be an hour, right? So we're aerobic at 90 seconds.
Yeah. So even in med school, I was taught this aerobic, anaerobic, and it was they trained us almost like it was a dichotomy, like it was one or the other. And it is absolutely not. It is a fluid continuum. I like to think about the words aerobic and anaerobic more about the energy demands that are being asked of the muscle. Can they be met with 100% oxidative phosphorylation, which is aerobic, right? If you're doing enough work to where that system can no longer provide all the energy needed, you're going to dip into anaerobic. That doesn't mean the aerobic stops. It just means that now you've dipped into anaerobic and you start to use sugars, use carbs, and that's zone 3. That's where that tipping point occurs. So that's a great way to get people kind of feeling it out and understand what you're talking about, because what you're doing is you're training that point. You're training your body to do the best it can with oxygen only, reserving all that good, fast-burning fuel for moments you need it.
I think that's great. The one thing that I'll add here, and this actually kind of will take us into our next topic, is it doesn't mean we don't need to go hard sometimes.
Correct.
Because if you never go hard, your muscles and your tendons won't be ready to go hard when you race. And so we do need to build up resiliency in the connective tissue. And oftentimes zone 2 training does not give us that. And then, I'm the perfect example of that. I can, I zone 2 train a lot, but then I want to go race a 5K, and aerobically I can run really fast. But because I've been going slow for so much of my training, my tendons and muscles aren't potentially ready for that, and my nervous system isn't necessarily ready for that. And so we do have to still go hard sometimes as well. So it needs to be a balance, or you're going to get injured.
Yeah, and it's a great point. Part of that periodization program, you swap zone 2 for interval training and hard training the closer you get to the season. So for instance, 3 to 4 months before the race, you're doing 3 to 4 days per week of zone 2. The other 2 days, you should be doing hard runs. You should be doing intervals as well as just steady state hard runs until you gas. And then as it gets closer, those switch. You start doing higher intensity sprints and intervals, and maybe a fasting all out run, or just switch up to really get into zone 3, 4, and 5 as you get closer to the race. then during the season, you just cut it down to 2 days a week. And you can even cut the time as well down to an hour, maybe even 45 minutes during the race season of Zone 2, and incorporate lots of rest because staying healthy and staying fit to participate in the rest of the season, you're going to need your recovery days.
Yeah.
Dr. Barnes, I just, this is great information. I actually just looked up my Strava for my ride this morning on my Garmin Connect, and I realized that Strava has the zones based upon max heart rate, which I can never reach because it's just using a 220 minus age. How do you, how would someone go about adjusting their zones within programs like Strava or Training Peaks or Garmin Connect?
I'm not familiar with those software, the hardware. I'm not familiar with them. But the 220 minus age is kind of fallen out of favor quite a bit lately. I would really use the 208 minus 7% of your age.
Okay.
And the other thing is you could also test your max heart rate. You can do a VO2 max test, and that will tell you what your max heart rate is, and you could just go off that. Another thing that you can do is you could do your own 6-minute rowing, right? Maximum exertion test at the gym and just watch your Garmin and see what you get to.
That's perfect. Thank you.
And I'll add this too. There's, if you go to the internet, there's lots of tests that you can do to test your max heart rate. So there's ones you can do running, there's ones you can do cycling. For those of you that Zwift, get into a short Zwift race and see what happens to your heart rate. It's amazing. I always max my heart rate on a short Zwift race. So there are ways ultimately to do it without the formulas. And then like something like Training Peaks, John, I know you mentioned that, or Garmin Connect, you can override the zones. Even on Strava, you can override the zone and set your new max heart rate. And then in Training Peaks in particular, there's I think for running, I think there's 6 or 7 different formulas that you can choose from, which makes it confusing for people, whether it's based off of max heart rate or lactic threshold or whatever. There's a lot of different formulas. So, all right, good. Let's move on. That was really, really good stuff. And let's transition into some of these more hip pathology, overuse injuries. So when we talk about these things, and why I actually asked Dr. Barnes to talk about these things is it seems it's ubiquitous in endurance athletes that we push ourselves until the point where we break, and then we stop and we, okay, now let's figure out, well, what do I need to do to get better? And you touched on recovery a little bit already and how important that was. But we're hard-headed A-type personalities, a lot of us, and that's not how we roll. So what can you tell us about, number one, I guess, why endurance athletes get overuse injuries, and then what can we, in particular around the hip area, and then what we could potentially do to mitigate those things?
Sure. So I would posit that hip overuse injuries are a common injury in triathletes because of all 3 sports. Your hip joint faces its own set of challenges in each position during running, cycling, and swimming. And particularly, like for instance, the swimming challenges the rectus femoris greatly, right? Versus the biking challenges the iliopsoas, right? Versus running challenges the glutes. So like every part of that sport, every part of a triathlete, every part challenges something different. And having a comprehensive program to make sure that those units work together, that they're maintain flexibility, that they maintain strength, is usually not on someone's mind because they're just out there training, trying to get faster, rather than taking a step back, looking at the fundamentals, looking at the anatomy, thinking about tissue healing time and tissue recovery time. So I feel without a dedicated program to address these things and to make sure you're maintaining the structures, most triathletes might fall into an overuse syndrome because they're not actively tracking it, something as diligently as they would track, such as heart rate or power output or, lap time or things like that. The function of all the muscles in the hip need that kind of attention as well.
Yeah, no, I couldn't agree more. I think that when we look into the research on this, not even the research, or even anecdotal evidence, triathletes they're overusing themselves already, right? They're doing 3 sports. And, I think most people on the call here, I would say it varies between 6 to 12 sessions a week of doing something, swim, bike, or run. And then it's like, okay, well, I don't have time for this. I think that we need to take a step back and once or twice a week, get rid of a run, get rid of a bike, get rid of a swim, and do preventative maintenance.
Yeah, I couldn't agree more. Most people fear that they will lose athletic prowess very quickly when they stop doing some physical activity, when in fact the data is quite opposite. Let's take a triathlete in this example, right? Run, bike, swim. Let's say you just cut the swim for a week, maybe even 2 weeks. If you're continuing your bike and your run, the evidence shows that you are not going to lose performance in your swim. Now, if you were to cut it all and go on vacation and eat a bunch of crap and drink a bunch of beer, yeah, you're going to lose some performance. But even when people completely rest from all athletic activity, it still requires 9 days for your metabolism and your strength to really start to decrease to a point where you have to work to get it back. I think people greatly underestimate the importance of rest. And I think a lot of that is for fear of losing the gains that they've worked so hard for. So you can take 2 days off in a row from everything and just do some stretching and go do something else, right? Go do something else active, that requires you to work hard, but isn't those 3 things. And you will see that, like, you will not lose your performance. It's okay. And in fact, doing something else encourages the neuromuscular connections to the rest of the things you haven't been doing. So God forbid you need to do something that you normally don't do during a race, like dodge a pothole or something like that. You're going to be ready because at least a few times a month, you've gone and done something that required maybe some lateral movement rather than just straight ahead.
Yeah, no, I couldn't agree more. And it's so critical, but I'm telling you, it's a difficult thing mentally to get past. Right. And, I had a pretty bad injury that you helped me with this year. And, I took 6 weeks off pretty much, off most things. It took me a month and a half to get back to where I was. Yeah. And then the pools got shut down. So who knows? My swimming's not where it was, but ultimately it doesn't take that long to get back. Even when we're forced to take rest. And there's lots of research on this. There was a good research article. I can't remember who did it, but it was with the Boston Marathon, and they had elite runners that basically they forced them to take a month off afterwards, and showed how quickly they could actually get back to elite level after a month. And it was amazing. I think it was less than 2 weeks.
Yeah, it's not long. And so please rest, recover. That's the other side of the coin. There's the train and the recovery. You need both sides. You cannot do one all the time.
And especially, with people that, they have full-time jobs on top of this and families on top of this, the rest it seems to be the last thing. I'll add one other thing that kind of, I know we weren't really going to go down this road, but like the primacy of sleep with rest, right? Mm-hmm. So many of the triathletes that I talk to and I know, they wake up so darn early because, I got to get up at 4 because I got to get the kids fed at 6 and to school at 6:30. And so they're running on fumes, and then they get injured and they have these chronic injuries. And it's like, well, you're sleeping 5 hours a night. That's not sustainable. And the research is very good on this. You're better to stay in bed for 2 more hours and miss that session.
Yeah.
Than you are by waking up early and doing that. And then those lead to these big muscle tendinopathies and myopathies and issues that can ultimately be prevented. And I guess that's part of this whole thing is when we talk about these overuse injuries is number one is to prevent them from happening.
Yeah, preventing an overuse injury is much preferable to recovering from one. As my residency program director would say, an ounce of prevention is worth a pound of cure. So looking at these things before they ever happen, looking at people's risk factors and really formulating a plan to be preventative will pay dividends time and time again. A note on sleep. There's been explosion in sleep research over, I'd say probably about the last anywhere from 5 to 10 years. It's really started to gain a lot of ground, and as it should. Why are we spending a third of our lives sleeping, right? If it's not something that is absolutely critical, right? If you told anybody that this one thing can improve your performance by 33%, you're gonna listen to them, right? If you tell anybody you need to do a third of your life doing this, well, that thing better be pretty darn important. And sleep is. And there are many facets of how to get effective sleep. I would encourage everyone just to Google sleep hygiene and make sure you're hitting all those points first and foremost. And at minimum, 6.5, 7 hours even is really what's needed for the majority of the population to at least get enough of sleep cycles for meaningful recovery. And speaking from an athletic point, meaning athletic recovery.
And actually, if we look at like high level athletes, it's pretty well documented. People like Tom Brady and LeBron James and Steph Curry, 9 hours, 10 hours is not unusual, especially during the season, for them to recover. And I know we're not all professional athletes, and we don't have that ability always to get that amount of sleep, but I think they're telling us something with that and the primacy they put into sleep. So that's great. So let's talk specifically about the treatment of overuse injury. So one other thing, I want to add this before I go. Many of you here have coaches and are coached, and I don't want to say anything bad about any coach, and I won't. But an article I was reading recently said that preparing for this was that overuse injuries are coaching errors. As simple as that. And many of us are self-coached, so we're making our own coaching errors. A really good coach will never allow you to get to this point. If everything is perfect, you should not get an overuse injury. That being said, it still happens. That's the one caveat I wanted to add.
Yeah. So I would say that the primary cause, when you look down at an anatomic level, at a function level of any sort of muscle that you're looking at for possible overuse, is really going to be a combination of two things: inhibition and tightness. Is it tight or is it inhibited? Because I'm not going to say that something is weak, but it can be inhibited to where maybe your gait pattern or some other nagging problem that you haven't fixed is inhibiting the function of the thing you're eventually going to develop an overuse from, because it's not being active during the exercise. But primarily, I'd say the one's really tightness, muscle tendon unit, or an anatomic region being tight, like flexors, extensors, abductors, adductors. When they're tight is when I tend to see overuse become very painful, very problematic, and start to become performance limiting, and that's when they show up to me. So there's been lots of great research that has pretty definitively proven you really shouldn't do static stretching before endurance exercise, right? And you should not do the old bend down, touch your toes for 20 seconds and then go for the run, right? You should do dynamic stuff. You can do jump rope, you can do high knees, you can do butt kicks, whatever you'd like, but as long as it's kind of a moving stretch. However,
so I'm going to jump in. So you're saying that as triathletes, we need to and should warm up?
No, you should warm up, but should.
That's what I'm saying. We should, though, right?
Yes.
Okay, because I'm going to tell you. I'm going to guess out of the people that I know, less than 10% probably actually do a warm up.
And it doesn't need to be crazy. It could be 4 or 5 minutes. It doesn't need to be a lot of time. And it's okay to actually take that time off of your run so that you're not using more time. Because once again, this is a preventative strategy. This is something that pays dividends. If you just spend a little bit of time ahead, pays dividends on the back end to prevent injury. Now, I'm going to go even one step farther. We have data that has come out that shows the static stretching post-exercise reduces the injury rate, right? So that old in high school, bend down, touch your toes, okay, grab your quad, flex it. Those kind of stretches, I should say, actually do show reduced injury risk when done after exercise. So once again, another 5 minutes of cool down stretching after the exercise. And I would highly recommend people take that 10 minutes off of the workout, okay, and put it into stretching to maintain flexibility of these units. As you can imagine, as you exercise, your blood, these muscles are becoming engorged with blood, right? They're working very hard. They're pulling on the tendon a lot and for long periods of time. When you stop, okay, I'm sure all of us have felt it. When you stop, you feel tense because all of the blood and the tendons are engorged with blood, and it's just a normal thing for that muscle to be, it's the pump, if you will, to be engorged with blood and tight. And it's very important at that time to stretch them out to prevent the inflammation that you've caused with that pump from leading to things like scar tissue formation and to lessening muscle and tendon flexibility. As we've all heard, workouts are really about tearing the muscle down, and then you recover to build it back up, and then you go again, and you repeat that cycle over and over. But it's important to understand that at the end of the workout, you need to mitigate the tightening effect of exercise due to the inflammation, the muscle damage you cause to it by stretching out.
Yeah, no, I couldn't agree more. And the research is really pointing in that direction. Do you know much about time it takes to elicit these effects?
Yeah, so some data says 20, some data says 30 seconds. I advise my patients on an absolute minimum of 3 sets of 20 seconds of stretching for each muscle group, right? So if you do adductors, that's a minute, right? You do quads, that's a minute, flexors a minute, and abductors a minute. So that's 4 minutes, right?
Yeah, throwing a glute stretch there, maybe you're at 5. It's interesting. Some of the research actually shows there's even benefits if you go longer, if you have time, 2 to 3 minutes. So maybe like on a Saturday or a Sunday after your long run, long bike ride. I know the first thing we all want to do is jump into the fridge and down a bunch of food, but maybe just a few minutes of prevention here would really help. Yeah,
or do it while you're eating.
Exactly. Oh, I've been known to have a bowl of ice cream as I'm stretching. It's not a.
There's no reason not to start eating immediately after exercise to replenish as well as do your stretches. Exactly. I would advise waiting more than maybe 15 or 20 minutes. 15 or 20 minutes after exercise, you've kind of lost the window to stretch. So it's okay if you go prep a meal real quick and then stretch out on your living room floor as you eat it. That's totally fine.
The other thing that I'm an advocate for is when we have those areas of that are tight or hypertonic, is to massage and self-massage, foam rolling massage. I think that those are really, it can be very, very beneficial. And once it just takes time though, and you can multitask, listen to a podcast while you're, learn something while you're doing your foam rolling. I think that's a really good thing to do. So let's say we have.
Ted, let me jump in with one more question. How about with real fibrous issue areas like plantar fascia and stretching? What's your thoughts with that area?
I am actually not a proponent of foam rolling thick fascial areas such as the IT band or the plantar fascia. I am not actually a proponent. I would recommend more static and dynamic stretching. I would recommend like neuromuscular in neuromuscular facilitation stretching or muscle energy, if you want to look that up. Oh, by the way, I meant to mention, Ted, I'm a DO. I'm not an MD.
Oh, that's right. Sorry. Sorry about that. Yeah.
I would recommend not foam rolling really thick fiber structures like the IT band or the plantar fascia. And remember, those are probably the only two that I really tell people not to roll. Pretty much everything else I'm totally okay with foam rolling. That doesn't mean no soft tissue techniques, all right? No soft tissue massage or anything like that. That's not what that means. But specifically foam rolling, I would not do those two. Plantar fascia, you can roll your foot on an ice bottle, okay, but don't stand on it and really grind into it. And I wouldn't foam roll the IT band at all.
And honestly, we could have a full hour on plantar fascia or IT band, and maybe one day we
yeah, I got lots of good videos I could show of working with those things.
Yeah. Okay, so let's say we have an athlete that comes into you and they've gotten to the point where, you know, they can't run anymore because their hamstring is just so messed up. What advice do you give them?
Well, so the hamstring muscles are a group of 4 muscles. People typically think that there's only 3, but there's actually 4. And Ted, you discovered this yourself when we were working together.
Yep.
That you can't forget about the ischiocondylate portion of the adductor magnus, which does act as a hip extensor. So first and foremost, you need to identify exactly where the problem is, because where the problem is can also point to you as to what caused the issue. For instance, you know, if I bring you in and we do an ultrasound on you and I see it's your semitendinosus, you know, it's probably an overstride, right? It's probably reaching too far forward, getting that knee straight, right, with the hip inflection. So now I need to look at, are you overstriding? Versus if it's more of like a semimembranosus at the ischial tuberosity, you know, I need to look at your foot strike. So it really depends on what structures are involved that are causing the injury. In general, the answer is almost always going to start with a period of relative rest. And I say relative with emphasis because if it took you being a triathlete to get this issue, okay, certainly resting would include being able to walk around or, you know, go on your Sunday walks with your dog and your children, and that would totally be fine. That's not working your hamstring like a triathlete does, right? So it's relative rest. And I think it's important to have respect for the tissues, for the biology of the tissues. You know, we know that tendons only reach 80% of their maximum tensile capacity at 6 weeks. You know, and so sometimes it's hard to tell somebody that, but there's nothing we can do about that. That's just the biology. So sometimes the time frame is not what people want to hear, but that is simply what the biology requires. And we have yet to find a shortcut for that. So almost always it starts with a period of relative rest. What's nice is during that relative rest time, we could do lots of investigations. We can do gait analysis, ultrasounds, MRIs, x-rays, sequential physical exams, trials of physical therapy. You know, we can do many different things to try to solve the root cause of the issue. So what I tell people when they show up with these things is, one, I'm sorry, we have to shut you down at least for a little bit till we really put our thumb on exactly what's causing this. We need to evaluate to see how high grade this issue is. We need to build a custom program for you to identify your problem and your root cause, and bring them back. I bring them back usually maybe every 2 weeks, and start to, you know, do the physical exam maneuver that would bother them before, or, you know, tell them, okay, I want you to go for this long of a run before you come and see me again and tell me how you feel, things like that. Yeah,
I think, you know, the best advice that can be given, and I think you gave it, is everyone is unique and everyone needs a professional, I think, to really evaluate them and come up with a good plan. I find that often, you know, Dr. Google and the internet can be a nightmare for these people, because they're like, okay, type in, oh, hamstring strain. What do I do? And they get this list of, okay, these are the things I do, but that may not be causative, right? They may not find the cause. So we're looking at a triathlete. Well, once again, let's say hamstring, engaged swimming in one way, mostly as a hip extensor, running, knee flexor and hip extensor, biking, hip extensor, and any of those things could be leading to this. I mean, I've worked with people that you know, they have a hamstring issue and they think it's because of the run, because it hurts when they're running, but really it was a setup on their bike.
Yeah.
Or they're
And
over
I
kicking on the.
take a moment to point a bit of a finger at those bike seats, man.
Yeah.
They can be tough, and choosing a proper seat is difficult because everybody has different anatomy. So one thing I would always encourage anybody who has hamstring pain, particularly up by the butt, you need to take a good look at your seat. You need to analyze the way you sit on your seat. Those bike seats can be a tough one.
And my advice to them people is to find a professional to help them with that. Yeah. Right. Once again, just looking on the internet and looking online of like, oh, where my seat should be or what type of seat, or, oh, you know, that's a $300 seat, so it's got to be good. That doesn't mean anything. It really is about, you know, does it work for you? Yeah, I couldn't agree more. So let's transition this into the last thing we want to talk about today, because we got about 10 minutes left. And I wanted to talk to you specifically about regenerative medicine and platelet-rich plasma injection. And we can go even further if you want into regenerative medicine. I know it's an area that you've done a lot of training in and an area that you are very comfortable with. What can this type of medicine, or where do you see this working in an endurance athlete?
So this has been somewhat of a game changer for athletes who have chronic resistant issues. This is really where regenerative medicine as a field shines. We do pretty good with physical therapy and activity modification and, you know, changing shoes and seats and strides and, you know, hip extension, lean forward and gait and cadence and all that. We do pretty good. But sometimes there are some people that's just, it doesn't seem to work for them for some reason. That's where regenerative medicine really comes into play. I would say the base level of regenerative medicine is PRP. PRP stands for platelet-rich plasma, and the sky's kind of limit after that. Not really in the United States. In order to do some really crazy regenerative medicine, probably should go to Italy. But in the United States, there's lots of different stem cell techniques that we can get to at a later date. But PRP is kind of your entry-level regenerative medicine. I find it very useful for tendinopathies or tendinosis, particularly when I ultrasound someone's hamstring tendon, you know, patellar tendon, Achilles tendon, flexuralis, tibialis posterior, whatever. You know, it always looks like this swollen, just boggy mess, right? There's not a good fiber structure to it that's nice and tight packed, like a good solid cable or rope. It's just kind of fluffy. And what PRP does is it kind of attracts the attention of your body. I'm gonna just go and get into PRP and what it does.
This is great.
Okay, so platelets, let's back up 1 second. Platelets are a part of your blood, okay? And they're the primary initiators of the healing process in all terms. So for just a small example, say you just get a little cut on your hand, okay? You start to bleed, right? And then ultimately you get a scab. Well, that scab started because your platelet said, hey, we got a problem over here. Come over here and fix this, right? So it attracted some fibrin, which clotted it, which stopped the bleeding. And then the platelets released something called granules that have all kinds of signals to the body that said, hey, we have an issue. Get over here and fix it. The why this is so revolutionary for tendinosis or tendinopathy is because tendons have a terrible blood supply. They're almost completely avascular, to where if you get an injury in them, there's not much blood passing by to pick up that injury, to have the platelets stick, to release the granules, to call the soldiers to come fix the problem. So what we can do is we draw your blood, we isolate just the platelets, and we concentrate them, usually anywhere from 3 to 5 times the blood concentration. 3 to 5 times that is what we end up injecting directly into the problem. So basically, we're hijacking that system, supercharging it, and putting it directly where the issue is to really have a nice, strong signal to the body, hey, come here, fix this.
Okay, so clinically, what are your kind of expectations for when you do something like this? What do you see?
So PRP for me will never supplant good conservative management first and foremost, right? So I will never do a PRP without first making sure that we've identified biomechanical issues, that we've got them on a rehabilitation program, that we've tried a period of rest, right? So that has to be implicitly stated. That my clinical expectations is after the injection, you're going to be sore. I basically am giving you a bruise, because a bruise is just a scab on the inside. I'm basically giving you a bruise and wherever I'm putting this thing, right? So you're going to be sore. It won't be exquisitely painful, but it's almost like I punched you wherever I put the PRP. So you're going to be sore for maybe 3 to 4 days. You can't take any anti-inflammatories because that messes with the platelet function for 2 weeks after it. And then after that, usually it's been about 4 weeks, maybe coming up on 5 weeks after, they first saw me. And now with the rest and with the PRP on board, we can start to put you into therapy and start to challenge whatever structure was the problem in the first place. I find that people who have the PRP injection accelerate through their therapy a little faster. I'm not saying it's miracle, okay, but it definitely is on the order of 2 to 3 weeks recovery time improvement compared to those who don't choose to do PRP. And this has been pretty well reproduced in tendon injuries, particularly with hamstring tendons and with those hamstrings and Achilles tendons. That's been pretty reliable. 2 to 3 weeks, they're back at their sport earlier than case match controls that didn't get the PRP.
Okay. So, I mean, it sounds like it is a little bit of a game changer for those really chronic injuries. So that being said, why is it that people choose not to do it?
It's usually a cost or a fear of the procedure. So PRP, I've done, I don't know, maybe coming up on 100 in the past 6 months or so. I mean, quite a bit. And it's an insurance issue because it's still cash pay. Only one insurance that I know of has paid for it, and I don't even remember the name of it. And then 2, the fear of the procedure. An issue with PRP, and I wouldn't say it's an issue, it's just the nature of the technique, is that I can't use any lidocaine. I can't use Marcaine, lidocaine, I can't make you numb. I just have to put the needle where I need to put it, and I need to fill your tendon up with this PRP, which in itself is painful as well. Now, my practice has come up with some innovative strategies to reduce the pain, and a lot of people have opted for that and have been very happy. And that has kind of taken down a barrier to receiving PRP, but those would be the 2, price and just pain and fear of getting stuck with a needle. I don't even like needles, and I stick people all damn day.
Yeah, I think everyone would agree that nobody really enjoys being stuck by a needle. I mean, it's not a good.
Some people have a next level fear, and then some people just, just do it. I'm not going to enjoy it, but just do it.
So then, how would this be different? So I from a corticosteroid injection, because that's pretty popular too, right?
Yeah, that's a fantastic question. Okay, so there are just a handful of things that I believe, and the research supports, that steroid is actually the answer for, okay, as in the fix. Because corticosteroid is a very, very potent anti-inflammatory, okay? So it's very good at turning off pain, okay? But what it's very bad at is the health of tendons and the health of cartilage. So, for instance, one of the things it's fantastic for is gout. You got gout, I put steroid wherever your gout is, and you're going to love me, right? Because it completely turns off the gouty inflammation process. I put you on the proper medicines. It never happens again. It's a win. Everybody's great. Thank you. Bye. right? Or synovitis, right? If you have just an inflamed synovium for whatever reason, but whether it be biomechanical, trauma, whatever, steroid shot, fantastic, no problem. The issue is repetitive steroid injections weaken collagen-based structures, right? So they weaken tendons, they weaken ligaments, and they weaken cartilage when it's done repetitively. So I do not recommend steroid injections outside of those couple examples I gave, and maybe one or two more if I ran across them. Now, it's not to say I don't do them for other things, but it needs to be implicitly stated this is a Band-Aid. And if anything, in the long term, this is going to make you worse, and patients really need to understand that. Flip over to PRP. So PRP has all of the anti-inflammatory benefits of steroid without that other side. It's actually pro-collagen, right? So it helps recruit your body to lay down and to remodel into healthy tissue, healthy cartilage, healthy ligament, healthy tendon. So PRP, if I were czar, would replace steroid almost completely, other than just a couple things. And in fact, there's been several large meta-analysis and randomized controlled trials over the past 3 years that have shown that, particularly for knee osteoarthritis, that PRP is superior to all other forms of injectate. Well, I shouldn't say all other. Superior to viscosupplementation, such as the gels, and to steroid. So it's really the thing you should be reaching for instead of a steroid for the majority of cases.
Well, it's interesting that, insurance pays for it. And so that's why people tend to go that way, right?
I know, and you're just shooting yourself in the foot, because most of these cases, the insurance is paying for this steroid. What they're really doing is paying you for the steroid because you're going to do another one, and it costs them more and more, and it's just going to keep going.
Well, thank you so much. So out of respect for your time, we're gonna cut it there. So we've been going for an hour. This has been absolutely fabulous. I hope the rest of the Tri Club got as much out of it as I did. I know this was just a breadth of your breadth of knowledge, and we really do appreciate your time. And
Can I do a small plug for my clinic?
Yeah, please.
I'm just gonna throw it up on the screen here. So this is my clinic. I should probably do it like that. There you go. So this is my clinic. We are over by Spring Valley Hospital. So the medical office building that's attached to the hospital is where our clinic is. We are currently working the coronavirus testing tent quite a bit. So sometimes we're in and out as of right now during this pandemic to help out with that. But please, if you guys have any questions, just call this number, 405-8150. Please leave your name and your phone number. We will get back to you, okay? There's our website if you want to learn about myself or my colleague who also works at my clinic. We'd love to see and help out any way we can. And I just really want to thank the Las Vegas Triathlete Club for having me. This was pretty fun.
And I'm going to jump in. I'm going to say thanks. This is just fantastic. Just a wide range of information, which was really cutting edge. I got to ask though, what is your exercise of choice when you go out?
I like to run and lift weights.
Oh, nice.
I'm a runner and I'm a weightlifter.
That's great.
Ted wants me to be an endurance athlete, man, but I'm young. I want to be big, not yet.
That's awesome. His run is getting better. We've been working on.
Yeah, with Ted's help, I shaved like 2.5 minutes off my mile. It was insane.
Nice. Well, Ted knows what he's doing.
Fastest 5K I ever ran was thanks to Ted.
I told him, I said, he could be a sub 25K, and he's like, no, I don't want that.
No, you said sub 20. I already did sub 25.
No, sub 20. That's what I said. I think you could be a sub 20.
Yeah, I did. I did a 21:58 right before my honeymoon last year. That was incredible.
That's great. Well,
all right, fantastic. Thank you so much, and we'll let you go. That was awesome. Thank you.
All right, well, thanks to both of you. You guys stay safe out there, stay healthy, and we'll see you later.
Okay, I'm going to stop the live stream. Thanks everybody for listening. Okay, the live stream is done. I'm going to stop the recording.